Can I bring the public board into session and welcome everybody. We have apologies from Simon Wesley, Jackie Rock, Rakesh Kapoor, and also from three of our colleagues who were with us this morning in the private board, Jeremy Townsend and Andrew Morris and Susan Kilsby. Can I ask if anybody has... And we have technology with us, that's all right. Can I ask if anyone has any interest to declare a newly arising interest since the last board meeting? Thank you very much. And can I ask the board for their approval of the minutes for the meeting held on the 27th of July?
Yeah.
Thank you very much. So I'll adopt those. Let me just give some reflections at the start of the meeting as chair. And in starting that, I'd just like to thank colleagues, actually, for all their work outside the board meetings and in various committees, as well as engagement across the NHS. So actually, since the last public board meeting, we've had two strategy board meetings and also a board deep dive session. And on the committee work, there have been 3 people and remuneration committee meetings, 1 data and digital and technology committee, 1 workforce training and education committee, 2 new NHS England committees, 1 audit and risk committee, and 1 quality or patient safety committee. So I thank my colleagues for all their endeavours in those meetings. I should start, though, I think, on the topic of industrial action, which clearly is continuing to cause huge disruption across our services, and this week has been particularly difficult for colleagues across the NHS. It has felt very pressured. And while Christmas Day cover is being provided, we aren't seeing Christmas Day levels of demand. It's clearly much higher. And the NHS has now seen our hospital doctors undertake 720 hours of industrial action in total since March, equivalent to facing a full calendar month without a significant proportion of our medical workforce. Now, our staff are doing everything they possibly can to keep services going, but it is simply not sustainable to continue to operate with this amount of disruption. And last month, we saw the number of routine appointments postponed, ensuring the NHS could continue providing emergency care during strike action surpass 1 million. We know this is an underestimate of impact because hospitals aren't scheduling on known strike days. Now, behind every, and this is a really important point, that behind every rearranged appointment or procedure is a patient experiencing added distress or anxiety or pain or deterioration potentially in their condition. And it's not just rescheduled appointments and operations, there is also the financial impact for trusts. There is pressure in urgent and emergency care, and there is the administrative burden of setting up and standing down work and the continuous sorting out of rotas. And I've heard this week about problems it is having on discharging patients, and there are simply not enough staff on Christmas Day cover days to complete the usual tasks while also dealing with business as usual levels of demand. And it will be impossible, I think, to manage this coming into the winter period with flu and COVID and other respiratory illnesses circulating and adding significant further pressure to our services. But we will continue, of course, to do all we can to keep caring for patients, putting them first. But we urgently need to see a clear path to resolution and for all parties to work together to do the right thing by patients and to find an agreement to this dispute. I know Amanda will also comment in her Chief Executive reports upon industrial action. It's important to recognise that since we last met as a board in public, the Lucy Letby situation, and actually, again, everyone would have seen that the Cheshire Constabulary has launched a corporate manslaughter investigation following Lucy Letby's convictions. The investigation is in its very early stages, and I know the Trust will continue to work closely with the police on this, and we will also cooperate fully with the statutory inquiry announced by the government. It's important that we as a board continue to discuss what actions we are taking so that we are doing everything within our powers to prevent anything like this ever happening again. And while these appalling crimes were the actions of a single individual, the case is also a stark reminder of the importance of NHS leaders listening and acting appropriately to the concerns of patients or families or staff following whistleblowing procedures and good governance. We've done a number of things. We've strengthened, as you know, the fit and proper persons test by bringing in additional background checks and ensuring that directors' fitness to lead is added to their staff record. All organisations providing NHS services are expected to adopt the updated strengthened freedom to speak up policy by January 24 at the latest. And we've also asked our NHS leaders to ensure that staff have easy access on how to speak up. And we've asked boards to report regularly to review and to act upon their available data. And clearly we've been having a series of very important conversations with our various partners on the topic of regulation. Moving on to NHS England and what's called the restructure. And my thanks here to Wal Collada, who's chaired the new NHS England committee, and to Steve Russell, who's leading this exercise as an executive, but also my thanks to the executives for actually dealing with what is a very, very significant transformation. So as we continue to focus on the organisational restructure of NHS England, having merged with NHS Digital and Health Education England, we're now on track to deliver an approximate 35% reduction in our headcount, or over 8,500 working time equivalents. It does project a saving of over £400 million, which will go to the front line and is equivalent essentially to funding around 8,000 nurses. In saying that, we absolutely recognise it's a difficult time for many of our colleagues here and also in the regions, but the important thing is it will allow us to reduce bureaucracy, to debureaucratise, and to focus on greater devolution to the ICBs, enabling the ICBs to continue to step forward into the very significant role that they have within our ecosystem. Moving on from that, I'd just like to make a couple of comments on personnel issues, starting with the non-executives. I'm just delighted to announce, actually, that Mike Hoop and Jeremy Townsend, their terms have been extended now for a second term of office. This will allow Jeremy to continue chairing the Audit and Risk Committee, providing very much valued business continuity as we manage this merger and organisational restructure. And Mike will continue to provide his very valuable insights and commercial experience, and particularly to the Data, Digital and Technology Committee and the new NHS England Committee and also the Quality Committee. So thank you to both of you for agreeing to serve another term. I'm also delighted that we received clearance for David Behan to continue until the end of August next year. And I know he is keen to continue to support Navina on embedding Health Education England into the new organisation, and for me, even more importantly, actually, on the next stages of execution and implementation of the long-term workforce plan, which is an essential delivery for the NHS. And then for new non-executives coming to the board, just to say that we are now in the final stages of clearance. So we have interviewed, we've shortlisted, we've made submissions of those candidates who we propose have the potential to come onto this board. Those approvals are now between number 10 and the Cabinet Office and the Department of Health. And I would hope actually that I'll be able to update the board very soon on which of those candidates actually are going to be appointed. In executive personnel, can I just I'd like to welcome Vin Doaka to his first board as interim Chief Transformation Officer. Vin had been working very closely with Tim Ferris in his role as Medical Director for Transformation and Medical Director for Secondary Care. And Vin continues to provide very strong leadership on our transformation priorities, including strengthening the effective use of data to deliver improved care through projects such as the Federated Data Platform. And Vin, my thanks to you for all you're doing there. I'm also very grateful that Jim Mackey is also joining us as interim COO while we appoint to the role permanently. And Jim will be supported by Sarah Jane Marsh in her role as Deputy Chief Operating Officer. And they will be updating us on elective recovery and winter preparedness later on in the agenda. I think Sarah Jane is also still the National Director for Urgent Emergency Care. So both of you extremely busy executives, and our thanks to you. Just some highlights since the last board meeting. We've had two primary care or stakeholder breakfasts, round tables, and they predominantly focus on discussing changes to older people's care. And we were joined by community nursing colleagues, experts in geriatric care from both the NHS and the voluntary and community sectors, by allied health professionals and representatives for care homes and local councils and primary and community care, and also a number of patient representative groups. These were very, very good sessions. Some of the key takeaways: the importance of early intervention and prevention, and also the vital role that community assets play in this. Workforce to think about skills rather than roles. That was a very important reflection. Importance of flexibility of commissioning for local areas. So what's the point of intervention? What's the place at which this best offers? And then healthy ageing. How should the NHS work better with its partners to make the most of every single contact? The two strategy sessions that the board held on the 5th of September and yesterday, actually the 4th of October, we were looking at specific areas for transformation. So looking at demand management through a focus on cohorts of population rather than just pathways, and where we can improve our offer to patients while also creating a more sustainable NHS for the future. And the first session looked at older people's care, it comes up again, and also primary care transformation. And the board discussed what key enabling factors might be needed to make a significant step change in both of these areas. And in particular, what is it that the NHS needs to do to support local innovation at place level? The second session looked at shifting acute care out of hospital and planned care through the framework of supporting, again, older people with more complex needs. I'll speed up a bit now, so I apologise if I've been going on a little. I was delighted to be invited by Professor Nick Maynard to give a keynote speech at the Orgis annual scientific meeting in Oxford, and then I visited the John Radcliffe Hospital site, where I was shown the ambulatory assessment unit. I also visited cellular pathology and histology with Annie Sykes and her colleagues, and I had a very good meeting with the chair and CEO of BOB, or Buckinghamshire, Oxfordshire and Berkshire ICS. Separately, and with Amanda, I joined the NHS Assembly for a session reflecting on the NHS at 75, and it's really important in that assembly to hear the voices of patient representatives and experts about their experience. Separately, I've had a Q&A session with the Confed network of mental health trust chairs. I shared the board's priorities with the mental health trust chairs and stressed the aim of the restructure I talked about earlier was to reduce bureaucracy and to enable and reduce that sort of circular reporting that goes on and improve connectivity to the front line. And they highlighted back to me their main issues of concern, and many of those are similar to those we see across the service. So questions of workforce, very clear financial pressures, focusing on staff well-being to improve retention, and generally actually surging levels of demand in mental health, which we know is a very significant challenge that the NHS faces. I had a very good meeting with the crossbench peers. My thanks to Mary for enabling that, and that was a very good exchange of views actually, and a number of very good questions were asked by members of the House of Lords, which we're taking away and we're following up on some of those questions. And earlier this week I did meet with the new chair of NHS Professionals, Dr. Helen Phillips, and the chief executive, Nicola McQueen, and I met them with Navina. And we spoke about the future strategy of NHS Professionals and how we can improve our relationship and make better use of their service to help with workforce issues, so the better management of bank and actually improve management of international recruitment. So let me finish with those chairs' comments. The agenda today, I think, is a good agenda. Again, operational performance update, then a financial performance update. We're going to have a session on learning disability and the autism programme, and I welcome Tom Cahill on that. We're going to look at the 3-year delivery plan for maternity and neonatal services, which Ruth will lead on, but she's joined by Kate Brintworth and Duncan Burton and Ngozi Idiosagi. And then the delivery plan for recovering urgent and emergency care. So a very good agenda. We also, this morning's meeting, we did touch on a series of other items in private board, winter plan update, the Q1 business plan report, execution of the long-term workforce plan, the implementation plan led by Navina with David's support, and operational planning guidance, as well as a discussion on our current progress with the federated data platform. So at that point, and thank you for humouring me, I'm going to hand to the Chief Executive for her report.
Right. Thank you very much indeed, Richard. And just to echo your welcome to both Vin and to Jim in their first board and their interim roles. It's great to have them both alongside us. There's a few areas, Richard, I'd like to pick up, if I may, starting with what has happened at Countess of Chester. So Richard has already talked about some of the issues that we've been looking at since the verdict in the Lucy Letby case. And I know this isn't lost on anybody here, but of course at the heart of this are families who have experienced unimaginable pain and will continue to do so, or likely continue to do so for many years in the future. So we are, I think, all absolutely committed to doing everything that we can to prevent anything like this happening again. Clearly, as a board, as an executive group, indeed as a wider LHS leadership community, we have spent a lot of time over the last few weeks thinking about, even at this early stage, what we can learn, what we should do, and that's obviously in advance of the Thirlwell inquiry starting. That's also true of the experience of Martha Mills and her family, which has come to prominence in the last few weeks and has highlighted, again, amongst other things, just that need to make sure that the voices of patients and their families are properly listened to, which I know is a theme we're going to come back to when we talk about maternity later. So I would like to just thank, if I may, Ruth, Steve Powis and also Aidan Fowler for their leadership on these issues over the past couple of months in particular, but also the scores of people who've been lending their expertise and experience to the discussions that we've been having. The themes that have come through, I think, consistently from the discussions have centred around culture and leadership, as well as the obvious things around things like governance and data, but also how we can make sure that in focusing on culture and leadership, we are unlocking that much sort of broader set of issues that then flow from that around patient safety, quality and experience more generally. So colleagues on the board I know will know that I have convened 2 meetings with a series, with a fantastic group of colleagues from not just within the NHS but our wider partners and experts to specifically talk about regulation, leadership and management, but also to talk about patient safety. What I heard in that meeting and elsewhere is that there is, I think, a broad consensus that alongside accountability for leaders, which may include regulation, there also needs to be support to meet them, and that includes ongoing training and development. So we're going to continue to work with partners to develop this work, both on leadership, management, and that's obviously very much part of the work that Navina's been leading on implementing the recommendations from the Messenger review last year, but also we're going to continue to work with Steve, Ruth, Aidan on what we can do now to reinforce the importance of patient safety and to make sure that alongside, as I say, the ongoing work on things like data and governance, we are really putting the listening to patients and their families at the heart of everything that we do. Richard, you've talked about industrial action, but I would like to say, if I may, just a little more about it. Of course, that has been, I think, operationally for the NHS very much the top focus for the last couple of weeks. But it's required significant focus over the last now 10 months. Local teams have done an extraordinary job in managing the disruption and supporting colleagues. But we do know that with every period of action, things get harder. So more than 60 days have been directly impacted by strikes involving multiple organisations, with each period obviously causing disruption, not just during action, but in the run-up to and the aftermath of those days. And since the beginning of strikes, more than half of the weeks since industrial action began have had some form of strike action, and some of those have been significant, some of them have been a bit more localised, but they have all had an impact. Worth noting, I think, that since the beginning of July, 8 out of 14 weeks have been directly affected, and we haven't gone even 4 weeks straight without a strike. So we know that more than 1 million appointments have been rescheduled, but we also know that significantly more appointments and procedures have been displaced, potentially impacting hundreds of thousands more patients. We've also seen, though, that through the, again, incredible hard work of NHS staff, the overall published waiting list was flat towards the end of last year. I know Jim will say more about this. But in fact, once you adjust for kind of usual seasonal fluctuations, the list did stabilise between January and May of this year. But clearly, that has not been able to be, could not be sustained, given the sheer scale of strike impact. So the NHS has now seen hospital doctors undertake 720 hours of industrial action since March. That is equivalent to facing a full calendar month, 24/7, without a significant proportion of our medical workforce. And of course, this is having an impact beyond planned care. So in emergency care, we know that the focus has been very much on patient safety, seeing patients as quickly as possible through the front door on strike days, but that has stretched staffing very thin in other areas, which we know has had direct impact, not least on slowing down discharge in some areas, and it's also meant clinicians have had less time to focus on their usual work. So, as it has been throughout, our priority, and we know the focus, I know colleagues know, the focus of our discussions with both unions and government continues to be patient safety, both of those who need emergency treatment and those waiting for planned care. And we all want to see, I think, serious discussions resume between unions and government, and with winter approaching, that cannot happen soon enough. So it's important, Richard, though, that as you have been, in being open about the impact that strikes are having on recovery, particularly elective care, but not only elective care, we also just talk about the cost of that action. So we have had some recognition from government of the additional costs. We aren't taking our foot off the gas, despite the obviousness of the pressure on people's time, but also the obviousness and increasingly clear financial stretch that it is bringing. So I think it is worth us highlighting as we come on later to talk about some of the financial impacts, but it is worth us highlighting that actually despite all of those pressures, for example, in diagnostics, the NHS has delivered 25 million key scans over the 12 months to July. That is 50% more than a decade ago, and waits of more than 65 weeks, which is the thing that we've been focusing on, particularly in elective recovery. By the time we got to the end of July, it's actually 59% down on the peak from June 2021. So loads more work to do in an increasingly difficult environment on elective care, but actually worth saying that the NHS has done, I think, an extraordinary job in maintaining activity despite that. Despite a very pressurised summer, we are seeing faster ambulance response times and improvement, although small, in 4-hour performance compared with last year. And in primary care too, we've been averaging over 1 million more appointments a month, and more than half continue to be the same or the next day. So we need to talk about the implication of where we, I think, are with the impact on performance. Jim will pick that up in a moment, and we certainly need to just, I think, acknowledge the pressure it's putting on the financials. But I think I did want to take this opportunity to give credit to colleagues across the NHS who have just worked so unbelievably hard to do the right thing for patients throughout. So maintaining momentum, Richard, on the urgent emergency care recovery plan. We had a very good conversation about that in our meeting earlier, which includes delivering on the additional extra beds, for example, will be particularly important as we get closer to winter. But also worth highlighting that another thing that is a critical part of our urgent emergency care recovery plan is helping people to stay well. So our winter vaccination campaign is hugely important. Last winter, we were under real pressure, as colleagues will recall, in January from both flu and COVID. So we had the twindemic last year, and that's why we had planned the campaign this year to better align peak protection with that period. That obviously had to change change due to the emergence of a new COVID variant, and Steve and his team have done a really excellent job in pulling forward the campaign and already now delivering 3.6 million COVID boosters and 5.7 million flu vaccines. As usual, frontline health and care workers are eligible for both vaccines, and I know, again, Ruth, Steve and our other chief professional officers will once again be lending their voices to local campaigns to achieve high levels of uptake so that we're looking after our staff as well as we possibly can as we head into winter. Also worth saying, I've only got 3 more things, I promise, but worth saying a bit about our plans for a federated data platform for the NHS, which Vin is now leading in his new role and may want to say a bit more on. But we've run an incredibly thorough procurement process over the past few months, and we are expecting that to conclude in the coming weeks. I think there is a broad consensus on the need for the NHS to better link up the data we have to deliver care more effectively. But we do know that we need to take people with us on that journey. So that's why last week we also announced a major engagement programme starting in the new year to gather public views on digital and data transformation in the NHS. Final 2 things. We should mark, and I'm sure Steve will want to say a bit more about this, but we should just mark, I think, also the welcome news from government this week that they'll be taking action to reduce the number of young people who take up smoking. This was a recommendation of a review. I know colleagues will remember this last year, and lots of colleagues in the NHS nationally and locally fed into that review. So I'm confident that it will be welcomed across the service. The human and financial costs of smoking are seen in every part of the health service and play a significant part in health inequalities, something we've been addressing with our lung scanning trucks in supermarket car parks and elsewhere, offering current and ex-smokers the opportunity to have an on-the-spot check. So although none of this and none of that excellent and really important work is going to become unnecessary overnight, or indeed become this isn't an overnight fix. Nonetheless, this is a really significant long-term intervention, and again, I'm sure Steve will want to say a bit more about that. Finally, Richard, you've mentioned the work that's going on within our own organisation to create the new NHS England, bringing together 5 previous organisations. I know I've said this before, in fact, I think I say this every time we get together, but I do want to thank my colleagues within NHS England, because this is a period of significant uncertainty. It has been a huge change, as you've said, and at the moment we do know that an awful lot of people are uncertain about their future roles, supporting others who are going through the process or are dealing with increased workloads and capacity gaps, yet continuing to come to work every day to focus on the difference that they can make to make the NHS work as well as it possibly can and to support others on the front line. So my thanks to them, and my thanks to Steve for leading the process, and also now for launching what feels like a really timely and a really important piece of work across the organisation on how we create a new culture, new ways of working for the new organisation that are going to enable us to deliver on our ambitions for the new NHS England.
So, Amanda, thank you. I will ask Vin if you want to comment on FDP in a moment, and Steve on smoking. Just on that last point, just to re-emphasise it, I think it's often too easily said but little understood just how immense a programme of reorganisation and transformation it is to essentially to merge 5 entities actually coming together. To conform policies, to bring systems together, make choices, to conform data, to consolidate the relevant programmes and the interaction from the centre, a smaller, still expert centre with the systems, and to do that at the same time as reducing headcount by 35%. I mean, 35%. It would be hard to think of many other equivalent transformation undertakings that have been pursued or achieved, certainly in the public sector or in the private sector, actually, and yet the machine continues to run. So my tribute to the executive leader. You've chaired it well, sir.
No, it's only just to actually make the point that this was the plan that was put forward by the chief executive and led by the executives. It wasn't imposed, it's what they sought to do, and I think we would never have got anywhere unless that actually happened. So we forget that. It was your plan, and that's important that we acknowledge and recognise that.
Well said. Well, thank you. So, Vin, having given you warning, and it's your first outing in this board meeting, we throw the ball to you. Just any comments you'd like to add on the Federated Data Platform?
Yeah, thank you, Chair. So I think the first thing to say is just to remind everyone that I think everyone agrees the NHS has fragmented systems for managing data, and that causes immense frustration to clinicians and it causes immense frustration to patients. And it's really important that we don't make the Federated Data Platform something that it isn't. It is software, and it is software that enables you to view data from different sources in a single view on your computer screen that makes it easier for you to manage your patients, whether that's bringing down a waiting list or making it easier to discharge patients from hospital so that all of your caregivers have access to the same information. No data moves. It is software that enables you to see data in one place. The second thing I think to remember is that it has been procured by the NHS for the NHS. The procurement was run over several months. Over 30 different people scored the bids that came in from potential suppliers. No single person was able to influence the decision. Independent reviewers reviewed individual sections, and then those scores were then aggregated. I think the public can have confidence in the software because at the same time as we are doing this procurement, we are procuring privacy-enhancing software that we have, therefore, two different ways of protecting your data, and access to the data is very strictly controlled so that only those who need the data can see it, and in particular, it's only your clinician who can view personal level data. It cannot be reviewed by anyone else. It is software, and what we've actually procured are licenses for every trust in the NHS and every integrated care system, but the control of the data remains with the organisations who control the data now. So nothing has changed in terms of data security. And the final thing I just might say is that I think the public can have confidence in it for two reasons. One is, as Amanda says, that we have announced £2 million to conduct a public dialogue that is part of the Data Save Lives campaign. And secondly, that we will be setting up an advisory group composed not just of members of the public, but those who are experts in data from various organisations to advise us on any future uses to make sure that those are properly debated and controlled. But I think, and I think many around this table will agree, this will have a transformational impact on the NHS. As a clinician myself, I don't know a single clinician who has not used the software and said it has completely changed their lives in the way they manage patients.
Vin, thank you very much. Steve, do you want to comment on smoking policy change?
And Amanda, and like any clinician, I have spent my clinical career witnessing firsthand the terrible impact that smoking has on people's lives. I think everybody knows it's the major cause of lung cancer, but it also increases the risk of many other cancers, heart attacks, strokes, dementia, stillbirths during pregnancy, the list goes on. And so that's why, personally, and I'm sure everybody in this room will welcome the decision announced by the Prime Minister yesterday to bring forward legislation to progressively raise the legal age of smoking. And I think that will be seen as a truly historic, momentous public health moment. I am absolutely confident that it will be welcomed by clinicians and clinical leaders across the board, and we will certainly be doing everything that we can to ensure that it gets through Parliament and is enacted. It also focuses, once again, on the importance of prevention. And of course, there are some things that the NHS can't do in terms of prevention. Those population health measures, such as the one announced yesterday, we can influence, but that's not in our control. But there are many things that are in our control. So, for instance, for tobacco, we have been rolling out tobacco smoking cessation services across the NHS, and we will be continuing to do that. And of course, not in the speech yesterday, but in the material, in the announcement, details of the announcement that went with it, was an almost doubling of the funding to local government for smoking cessation services. And that's really important for us because our smoking cessation services in the NHS work hand in hand with those local government cessation services. So that is to be welcomed too. And we will continue, as you would expect, to focus particularly on the secondary prevention elements that we can focus on in the NHS, where we contact patients on a one-to-one basis rather than just those population health measures. But clearly they are both equally important.
Steve, thank you. And I, with no forewarning to you, I spoke about industrial action, and Amanda spoke about industrial action. I don't know. We wrote to the BMA, and you and Ruth and Navina and Jim all signed the letter to the BMA. Are there any other comments you'd like to add to what we said on industrial action?
I think it's important. Amanda has framed these discussions around patient safety. And one of our key roles as NHS England is to ensure that we support the NHS, all organisations within the NHS and all clinicians, to ensure that patient safety can be maintained. And I think it's our responsibility when we see risks to patient safety, either materialising or at risk of materialising, to point that out. We do that regularly in our updates to government, as Amanda has said, but we felt the time had come to formally raise with the BMA a number of concerns that are detailed in the letter around how industrial action is impacting upon NHS, and particularly our emergency and urgent services and patients who require maybe not surgery tomorrow, but in the next few weeks. We have been having ongoing discussions with the BMA operationally throughout strike actions. Those will continue, and we will be taking forward the issues that we raised as part of those discussions.
Steve, thank you. I won't get others coming. I know, Ruth, you signed the letter, as I said, and Jim, you signed it, and Navina. It's very important as a group of our four executives that you were signatories to that. I think it was an important step, actually. Can I move us on, though? I think I'm going to move to performance update if we can. So, Jim, I think you're up on operational performance, I think.
Yeah, thanks, Richard. So I'll continue the discussion really about what's been happening recently. So the report covers July for elective care and cancer, August for urgent care. Both feel like years away. It's been a very, very busy summer, as you can see in the statistics, very busy in urgent care, especially. In elective care and cancer, the NHS has managed to maintain very, very, actually surprisingly high levels of activity through all of the disruption. And you can see year on year really impressive reductions in long waits, stabilised a bit through industrial action, and in urgent care, improvements on category 2 response times and 4 hours. I'm sure Sarah Jane will mention them later on. We're also, continuing to work with the NHS all the time, just trying to navigate this complexity of industrial action, the churn associated with industrial action, the stretch that comes with that, and increasingly the financial pressure that comes with industrial action. And in recent weeks, that's been a very topical issue. So I've spent a lot of time with colleagues just helping with prioritisation, focus, and as Steve has said, trying to make sure we're all as safe as we can be in these times, because the service since these reports and during September has become very stretched. And I think everyone can see that in their day-to-day work. But hugely impressive performance in that context. If you'd said last year the NHS would have 11 consecutive months of industrial action and still be on its feet, I don't think anybody would have actually believed it. So really strong there. Awful lot to do, though, in terms of delivering the long-term ambitions. And on elective care, just a couple of additional facts here. So that one of the things we're really still hanging on to and taking heart from, even when things like list size have increased during industrial action and we've stabilised on long waits, is the 65-week cohort falls very consistently pretty much every week, even through industrial action, which is the next big goal that we're aiming for. We're trying to do everything we can to get ahead of the game for next year as well, where all the outpatient reform really needs to kick in, and we've got really strong returns from the NHS there as requested in the summer. So great support there from colleagues, and with Tim Briggs's further faster programme, again, some evidence coming through of real impact, although early days. And then just to top it off, we should remember as well that this isn't a waiting list for surgery. So it's often commented upon as a waiting list of 7.5 million people waiting for elective surgery. That's not the case. Over 80% of the people currently on the list will end their episode in outpatients or a diagnostic programme. That's exactly where we're focusing on trying to deliver change for this next period, so we can deliver long-term change. And also the 7.5 million isn't 7.5 million people. It's just over 6 million people, which we talk about regularly. I think it is very important in terms of coordinating their care appropriately, but also not misleading the public who see that headline every month. Very finally, just again, to just give heart, I've had a couple of sessions this week with colleagues here, with colleagues in Sussex, for example, and also Kings, who've been challenged in different ways, financial challenges, operational challenges, the challenge of industrial action. And both give real heart, actually, that people are really working very hard with complex decision-making, prioritisation, really strong clinical engagement in all of those conversations as well, to make sure that we do the right thing in these complex times.
Very good. Can I open up for comments or questions to Jim on operational performance? I mean, I would open just with it's reference on paragraphs 15 and 16 of the report about diagnostic capacity. I realise one of them is a comment on the recent increasing in our diagnostic capacity, but also the commitment to get to 160 centres by March. I mean, personally, when I came into this role, the fact that we have a significantly below OECD average diagnostic equipment, so we're not even at average OECD, we're significantly below that, I think around half the average of the OECD for diagnostic kit. It's really pleasing to see that. Your confidence in that rollout?
Yeah, absolutely. In terms of the investment on that investment for diagnostics, but also in surgical hubs, a lot of them are just coming on stream now, so we've got those benefits to kick in eventually. Clearly, it's a stretch on the workforce, so we need to make sure that it does present actual additionality overall, and colleagues here are working hard with the service to deliver that. There'll be a slight dilution because of industrial action there as well, but very confident that we'll deliver what we said we're going to do.
Thanks, Jim. Well, I think you want to comment. Well, then David.
Thank you. Thanks, Jim. Comprehensive report. This is going to be a hard question. I apologise in advance. But it's your first meeting, so.
None taken.
So, I mean, Amanda and Steve has given us a really interesting flavour of the impact of industrial action. And there's a sense in your report that you're sort of, surprised and delighted that despite all that, it's been in many cases remarkable that it's gone forward as well as it has done. But can you give us a flavour of some of the sort of the work that needs to be done pre and the post? Because in doing that, you're giving up something, right? There's a trade-off here somewhere. And you're storing up problems, not for tomorrow and the day after and the day after that. So it's much more than a today problem and just getting through. It's some of the stuff that you're just not doing.
No, absolutely. Yes, so that's a great question, Wal. And you look at this a few different ways. One is in elective care, you need to be able to plan ahead. One of the really big things that worked last year was our commitment to try and book patients in the cohort several weeks ahead and get that certainty for everybody, for clinicians with a schedule, and but patients as well to know when they're going to get treatment. Clearly, when things are going to get disrupted all the time, you're not quite sure when industrial action is going to happen. The builds in a hesitancy. So first of all, you're less productive than you want to be. If you talk to contact staff, booking staff, medical secretaries, those sorts of people, they are in a constant churn of cancelling and rebooking all the time. And having to tell disappointed people, worried people who might be waiting for a cancer diagnosis, etc., that things are being cancelled again, and we're going to try and get them in as quickly as we can. But there's an uncertainty all the time in all of that. We have been frustrated at times about the focus on just cancelled episodes, because it really is a very small proportion of the whole impact of this, because in the NHS, the service is just doing this now all the time. It's churning in a way that I don't think any of us thought we could actually do several months ago, constant cancelling and rescheduling. And that just builds in lack of productivity everywhere, but also just huge disappointment and worry on behalf of the patients. And clinicians want to see patients. Nobody wants to be sitting around, unable to do what they need to do. So it is very, very tense out there, and people are very fatigued with it. I think what we can see, and you can see a bit of this through summer and certainly in September, is when the NHS gets a run at this, it can make an impact. In weeks where there isn't disruption, the list will fall, long waits will fall. And as you can see in the data for last year, when we had a steady run at it over a few months, as Amanda said, we managed to stabilise the list nearly 2 years ahead of time, according to the plan. So I think that shows what the NHS can do.
Thank you. David, you were going to, I think you had a question or a comment.
Yeah, thanks, Jim. I just pay tribute to what you've pulled out here, which is the improvements that have taken place over those 3 months. I think that's really encouraging and plays off the back of Wall's question. But I just wonder, at paragraph 7, we talk about the waiting list being at 7.68, and it's a big figure, is that? And I begin to understand, sat behind that, if you begin to segment that figure, the numbers waiting for surgery, for instance, is very different than the 7.68. And I just wondered whether it might be helpful as we begin to present these figures going forward, if we can actually just break that figure down and segment it. I think it plays to the point you're just making about being more precise about what's going on there.
No, absolutely, David, absolutely. So, and in the initial part of this programme, when we first agreed the elective recovery plan, the long waits were very surgically orientated. The vast majority of patients on the list, I've said before, are going to see a physician, have some diagnostic processes and have things ruled out largely. So that is a very different thing, and we do really need to try and illustrate that in a more nuanced way. We're also trying to accelerate the first access for patients to first outpatients, and then at least start a process. So you're not on the list with just complete uncertainty, not being in a process as well. So over the next few months, we'll try and present the data in different ways to give a different feel for that.
Mark?
So prevention is always better than cure, and it's worrying that England's lost its measles elimination status.
Can someone tell us about, it may be for Steve rather than you, sort of the whole issue with the MMR catch-up campaign and where we are with that, and maybe at the same time to talk a bit about flu vaccination, particularly in health staff?
Yeah, thanks, Mark. Happy to do that. So, routine childhood immunisations, which obviously includes MMR, have been under a sort of progressive decline over the last 10 years. There are many, many factors behind that, but NHS England, working with UKHSA and the department, have got both an outbreak plan but also a recovery plan in terms of catch-up for MMR vaccination in particular. You'll be aware, colleagues will be aware, it's also very different around the country. So uptake in London has generally been lower than in other parts of the country, and that is probably where the greatest risk currently sits. So since the summer, NHS organisations in London have been running a community-based outreach offer for both polio and MMR. That was run in 2 phases. One was a general offer of a catch-up vaccination in the routine settings, which is normally general practice. And then the second part of it has been in-reach into schools and other venues where people have trust and confidence and go to with their children. So that continues to be undertaken in London, and then later this year and into next year there'll be a further national campaign, national call and recall run with some additional and different provider models as well. So looking at where children present and have contact with, and trying to put vaccination offers in those places with the professionals they meet. Just very briefly on flu, so I think as Amanda and Steve said, flu and COVID vaccination are very important protection for healthcare workers, both for themselves but also in terms of protection for patients. So the campaign has started. It's quite early in the season, so it's probably too early, Mark, to say where we think uptake trends might be. But again, NHS organisations up and down the country are doing all of the usual high-impact interventions, so particularly around peer and roving vaccination, so that you vaccinate in people's setting of work rather than asking them to go to a clinic that is often difficult to get to because people are busy. So we're monitoring that quite carefully and closely, and we'll continue to do so over the rest of the season.
Thank you.
So, Steve, thank you, and Jim. Can you just remind me on the vaccination centres? How many have we got? How many have we got open now compared with last year?
For COVID, there are about 4,500 sites active and vaccinating. That compares to about 2,000 to 3,000 in the spring and about 3,000 last autumn. So it's a bigger network and campaign this year. And flu is delivered in usually around 11,000 settings.
Very good. I'm keen to get Julian in, but I can see Ruth wants to make a point.
Jim, if I may, on elective recovery, I know that there was a piece of work over the summer about catch-up for children and young people on the elective programme. I'm just urging us to continue to really focus on catching up for children because it will affect their lives much more severely, so it's really important. Thank you for the work you're doing.
Ruth, thank you. And Jim, thank you very much. So, Julian, can we turn to you on the financial performance update?
Sure. The paper we published provides the numbers up to the end of July. However, what I'm actually going to talk about is the numbers up to the end of August, given that since we submitted the paper, we have had those, and it still tells a broadly consistent story to those in the paper. Up until the end of August, continuing a trend we have seen as we've gone through the year, and in particular accelerating a bit as we have had combined consultant and junior doctor strikes each month. We are seeing a total system deficit up to the end of August of just over £1 billion as compared to plan. That is clearly a really sizable number. In the context of spending by systems, it actually represents just about 2% of spend up to this point. Now, the dominant factor behind that, I think, is the cost of strikes. Our estimate of the direct financial cost of strikes, by which I include both the extra money that is being spent on strike days to pay people to cover shifts, in particular in urgent emergency care, plus the impact of lost savings, because just simply the kind of disruption of strikes and the fact that management clinical leadership time is focused on managing them, we currently value at £700 million up until the end of August. So as you say, that is like the dominant factor. In addition, we estimate that we have lost the equivalent of about £700 million of, in particular, elective activity. That is both as a result of appointments that we would have otherwise expected to have taken place, plus the fact that, again, we have been targeting productivity and efficiency improvements and change and transformation, which has not happened, which we think would have also given us further activity. And that is really what is then driving, as Amanda and others have said, we've lost at least 1 million appointments cancelled on those strike days. But in fact, we think we've probably lost more activity in the round over the whole period. So that's the dominant factor. It's not the only factor. We have seen also quite a significant increase in the cost of prescribing in primary care. Now, that is influenced by three things. One, just the fact of sort of global inflation has fed through into medicines prices. It really did start to feed through into the prices at the back end of last year, and that has continued through into this year. GPs are seeing a lot more people than they were. It's a thing that is worth repeating, but as a result, they're seeing people who need care and therefore are being prescribed medicines. Actually, and again, on the real plus side, it is also partly because we have seen quite a growth in the prescription of DOACs, which we would actually anticipate having substantial benefits for those who'd otherwise have cardiovascular disease or stroke. And indeed, we've seen quite a surge in the prescription of HRT. So those are the things which are, so there's some sort of good news actually in there, that we are seeing activity that we want to take place, and in particular changes in prescribing that we have been actually striving for are happening. But that is creating a financial pressure, and to give a sense of it, we're probably seeing prescribing spend grow by 4 to 5% annually, rather than for the last 10 or so years it's been growing by about 1% annually. So that's the kind of scale of change. Now, the third factor is that, notwithstanding the impact of strikes, I mean, many ICBs and providers have been doing actually an extraordinary job of delivering the plans, including, the proportion of the kind of efficiency and saving plans that they can, given the circumstances, and therefore doing what they said they would do. However, there are systems and providers who are struggling to do what they said they would do, notwithstanding the impact of strikes. Now, we are working through, where that is the case, systematically to work with ICBs, providers, individually and together as systems, to turn those situations round. That includes providing, sourcing, turnaround and improvement support as we judge appropriate, and to make sure that we are supporting those places to ensure that they have the right personnel in sort of a non-exec and exec capacity. So we are, we will continue to do that. We are seeing signs of improvement. I mean, I would say that we are seeing agency spending coming down across the country. That is one of the things we have really targeted this year, and indeed we are seeing provider spend has been flat, and there is some signs that it's actually beginning to reduce. I would say it's marginal, but there are some signs that as we've sort of got into the year, we are seeing people, despite all the challenges and despite actually the work they are doing to deliver the improvements in performance and sustaining quality of having appropriate control of costs. So we will continue to work across those three dimensions. We are obviously still in dialogue with government about how they want us to deal with the impact of strikes.
Thank you. Amanda, is there anything you would like to add as CEO as you think about the financial picture we face and as we head into winter?
Thank you, Richard. Well, I think Julian set out the position very clearly. I guess where we have been is very much encouraging, as Julian's just said, systems providers to continue to focus on delivery of their efficiency plans, sort of notwithstanding the disruption that's been described because of strike action. But we have been encouraging providers and systems to maintain elective activity, and also to continue to put in place those things which are going to give us maximum resilience as we head into winter, and also allow us to make progress on things like our primary care recovery plan that we've talked about at this board before. So that's been where we've been up to now. But I think, as Julian says, we clearly have had, which is very different to when we were in the planning process, a level of disruption to services in the NHS that just was not anticipated at that time, and that has now put us in a position where I think we are aware that at a local level, organisations are finding it increasingly difficult to get that balance right.
Thank you. And Munir, I think you wanted to comment.
Thanks very much. The
increase in prescriptions by 45% is enormous. But NHS England and various others have published reports that as you increase medicines usage, there's an increase in wastage as well. Do we have any idea what the degree of wastage is and what we're trying to do to minimise our wastage?
I think the best estimate is probably the work that Keith Ridge, our former chief pharmacist, did, who published a report on this subject, I want to say last year, but I can't quite, 2 years ago. Now, off the back of that, actually, we have done various things like we have had incentives in the GP contract and in the community pharmacy contract to sort of conduct structured medicines reviews to make sure that people are being sort of appropriately prescribed, and we continue to work with ICBs to sort of share data on prescribing patterns. And in fact, I would call out the work that Ben Goldacre's team do in actually publishing a lot of this data, which is available for use. So with them, we are working with ICBs to see, are we using it? And, are people talking to regional and local teams, in particular through the regional pharmacy network? But you might want to say something.
Well, there's an entire debate we could have on that question, but broadly it comes under the umbrella of medicines optimisation. So it includes ensuring, as you would know, Mania, that the right medicines are prescribed at the right time for the right condition, through to ensuring that medicines are reviewed on a regular basis to ensure that they're stopped at the right time if they're no longer required, and a whole host of technical things in there as well. So there are big programs going on nationally and also regional level around ensuring that the medicine usage is optimised.
Julian, thank you. Clearly, it's a very challenging financial picture. You commented on the higher volume of sort of primary care activity and the number of appointments and so on. I was just checking the operational deck, and actually, what we do see there, we've seen over 15% increase in the last 12 months. That we've recorded, so a 15% higher number of appointments than actually in the 12 months running up to March 19, the pre-COVID period. So we're seeing an increase in volume, which then drives that higher intervention, higher prescription. But clearly, you also referenced, I think, on prescription and medicine costs, actually the impact of inflation coming through. But industrial action, from your comment, is the main driver of the challenges we're seeing in the financial picture. I think that as a board, and led by you, Julian, we're very aware of these financial pressures and of our obligations, but importantly, we remain in guidance to our systems and to our trusts, when we are asking them to put in place the capacity to deal with the winter surge to look after patients. Anything you would want to?
That's fine.
Thank you very much. Okay, let's move on. So Tom Cahill, welcome. I think you're the National Director, for Learning Disability and Autism is your formal title, and you hosted for us just prior to this meeting, actually, a really good, broad-ranging but training session on Oliver McGowan. So the Oliver McGowan mandatory training, which I personally found really helpful, raises my awareness, makes me think about my interaction. I'm sure board colleagues would have felt the same, and I'm sure they'll comment. But actually, in particular, to Jeannie Northover and to Vicky Livingston Thompson and to Tim Heaven, who led that training session, I'd like to record the board's thanks. Actually, it was a really good mandatory training intervention. But Tom, over to you. There's a paper here on learning disability and autism. It follows up some comments in the summer about outcomes that actually we see in the health service for. Particularly on reduced life expectancy, actually often for those with learning disabilities. So.
Thank you. Can I begin by saying, commending the board on just having gone through the training, Oliver McGowan training, and then sitting and listening firsthand to Jeannie and Tim and the sort of lives they live and the things that we need to do to help them live those lives. So really, really commend the board on that one. I also commend the board on having this agenda item. I'm a bit nervous about all the questions, but delighted that the board is prioritising this group. Just a bit of reminder about context. I know I'm here to talk about health outcomes and that element about it, but just remind a little bit of context about the programme. We estimate there's about 1.5 million people with learning disability in the UK, and between 700,000 and 1 million people who are autistic. So it gives you an idea of the scale of the issue. The programme been operating around NHSE since about 2015, refreshed in 2019. And there are just 3 priority areas that I just put in the room. The first one is about people who are in hospital. And we know that we have about 2,000 people who are in hospital. And one is making sure there is appropriate quality. 2, getting people out who shouldn't be in hospital, and there's some really good work there. But also providing real alternatives in the community. And I think in the last 3 years, NHSE has spent about 121 million providing different opportunities for people to stay out. And one of them was key workers, which Amanda and I saw last week, which was really good. The second priority is health outcomes. And the anchor point for that is annual health checks, but much more. Really helping people with learning disability and autistic people get a better deal, get better outcomes. And then the third one, which is a probably newer, more 2020, was the autism programme. And whilst it is aligned to the learning disability, it is a standalone programme. Many people who are autistic do not have a learning disability. And that has a priority of about getting good practice around pathways. We know about the waiting list, making sure environments, the NHS environments particularly, are adjusted now to think about people who are autistic. And just remember Jeannie in that room and what she said about noise, touch, all of those things, really important. And health inequalities is a similar issue for people who are autistic. So the paper is there. Just a couple of points. You have seen the information from the last leader review. We're about to see the new one, and I can't say too much about that today, but we've seen the last one. Very stark about life expectancy. But the most critical one is probably perhaps is the avoidable deaths. And the word avoidable is the one that we need to grab on, and comparatively. And then compounded by the Race and Health Observatory report, which talks about people with learning disability from an ethnic background, which really talks even further about life expectancy, and really profound. And I'm really glad that you're wanting me back here to talk about it and prioritise that. We know, if you look at some of the data that's coming out around respiratory conditions, diabetes, hypertension, cancer, and if you just think about the conversation we've just had about waiting lists, there will be people who've got a learning disability and autism in those waiting lists, and we are talking to colleagues about, hang on, can we do some stuff? But it's not all doom and gloom, and just to pick up, so we've got learning disability improvement standards, which Ruth and her team are leading, which all acute hospitals are working to and trying to comply with, and best as well, we're seeing really good stuff there. There's a couple of examples of acute hospitals who are going the extra mile, and there are many, but I'll just pick out Calderdale, who are going through their waiting lists and fast-tracking people with learning disability. Leicester Royal Infirmary, fantastic stuff around disability, sending taxis out to get people into appointments, recruiting people with learning disability, and also appraising their waiting lists. And I visited the Whittington, who are doing what I would call pod videos for people who are coming into hospital, videos run by people with learning disability and autism to show to people who are about to come into hospital, whether it's A&E, whether it's outpatients. Really innovative stuff, but not mind-blowing. So really, really good to see that. If you see then about the Oliver McGowan training, and we can't endorse that enough, and we will continue to do it. But some really good figures, 2.5 million launches on the web since October 22 or November 22, 750,000 take up of part 1 of the training and the online training which you've just done, and there's 200 trainers already in that program. So really good work, and you'll probably have to take your hat off to Paula McGowan and her family for driving that. And Amanda and I met with her last week, and she's a spirited individual who we will support as best we can. You can see then on the paper, there's some of the key headlines that we have around digital flag. And I think it's a game changer if we can get this done and in. We're looking for 24. And you've heard the conversation earlier about how do you know if somebody needs a reasonable adjustment. If the digital flag works properly, we put the data in properly, and we use it properly, it is a game changer about telling. Now, it's for disability in the broader sense, but learning disability and autism are the pilot and driving that. You can see what we're doing, improving primary care and secondary prevention around COVID, flu vaccinations, supporting obesity and diabetes, which are particular issues for people with learning disability, cancer screening, and CVD and respiratory activities. The annual health check's really important to us. We've seen an uptake. We've target for 75% by 24. We're already at 78%. Really big push last year to achieve that. Just a cautionary number, 350,000 properly on the GP register. So we increased it by 12,000 last year, which is really good. But if you think about 1.5 million, there's still more to do. You'd never expect the 1.5 million on the register, but we know we've got more to do to get that. And we're now starting autism health checks. We're really doing some pilots about what that will look like. Clearly, LEADER is the next report's out, but we're continuing to plan and to drive the learning. And we have significant learning over years. And we often think about, do we need to keep doing LEADER because we know the data already? We'll keep learning new data. Cancer is something that we hadn't quite seen before for people with learning disability as an avoidable cause of death. And so we're now pushing on the screening of that. So we continue to learn from that. Stomp, really important around medication. And we know from the Oliver McGowan training, it's a reminder about the importance of, so it's not just about over-medicating, where probably perhaps Stomp started from at the beginning of the day. It's much more sophisticated now. Are we medicating people that helps them in their best way, and wherever possible, avoid medication. Autism waiting times, obviously a challenge for us. We are seeing an increase in activity as much as we're seeing an increase in the numbers being referred, but we are seeing an increase in the numbers being seen, but it is still a challenge. And clearly, this is going to be an issue for workforce. We have challenges with workforce that I think anyone in the room could talk about. And it's not just the nursing workforce, it's really about the care sector. Have we got people who can take people out of hospital and look after them? So we've got, and that begins to move sort of beyond just the health outcomes. So I think that's probably given you a sense of what we're doing. I think the ask I would have is we continue to profile this, we continue to champion it. We're talking to ICSs about what they can do locally, what can they do in their cancer networks, what can they do in their respiratory networks, and we would encourage that to continue wherever possible. There's something about just making this real, shining a light on particularly, it is not too big to deal with. If you look at it as entirety, it probably is, but it is not too big. There are things we can do, and we're already seeing them, and we're already seeing hospitals doing it, we're already seeing primary care doing it. So we just got to keep this momentum going.
Tom, thank you very much for those comments and also for a very good paper. Can I just open it up for comments? Or said David and then Ruth and then Mary.
Thanks, Richard. Tom, thank you very much. And thanks for the kind of positive presentation of the issue. And certainly, Richard, I'd really make a case for this coming back on a regular basis so we can actually do what Tom's asking, which is keep our eye on this. I think the avoidable deaths make the point about how much more there is to do. There's some quite distressing figures in there, and we touched on that at the last board meeting, but you're right to pull out what progress has been made. There's two issues, though, that I'm not looking for an answer for now, but there's two issues that just pulled me up short when I was reading the report. One is, do we have the right people in the right place? It's your point about people with learning disabilities being in institutions, which we know are not the best place for them. And I don't know what the benchmark is anymore on how many we think are there inappropriately and how many should be moving out, and whether we've got traction and visibility on that. You might, but I'm not sure it is to the board, and therefore I would make an ask that in subsequent reporting we can have greater visibility on that, because there where some of these quite distressing human rights cases come from, of people with incredibly complex needs being kept in isolation, etc., etc. And I do think, given what we had in Manchester earlier this year, there's a real need to keep that visible, because there is really an issue about who champions this group of people. So that's my first point. The Oliver McGowan training, I've been around services for a long time, but listening to Oliver's mother tell the story at the beginning of that training, I found very, very powerful indeed. And I want to pick up on the medication point. The STOMP training makes a point about medication. This is Mania's area better than mine. But I do worry whether we're putting the onus around making sure people are being given the right medication on families and not on the clinicians who do the prescribing. And my question is, what is the challenge to the prescribers of the medication to get that right, as distinct from the families having to champion this? And as I say, we touched on this over lunch, Tom, so I'm not looking for an answer, but I think it is something that we need to come back on, because Oliver's story is a very vivid example of, if that's not got right, what the consequences are. And I do think it's important to keep that in vision. Thank you.
Tom, we'll get the comments if you want to try and capture them and then deal with them in one go. So Ruth, I think you were next, and I'm coming to Mary, I think.
Yes, just 2 points for me. So the Oliver McGowan training was just a reminder about listening to patients, listening to families. And of course, we'll talk about that in a moment when we come on to maternity. So great tribute to Oliver, and I'm very happy personally to have been supporting this as well. So thank you, Paula, and thank you, Tom, for your enthusiasm of it. With regard to workforce, because you've mentioned it, whilst we've got more nurses now this year than we did have last year, we've got the most ever healthcare support workers we've ever had ever. Mental health nursing and learning disability nursing in particular is the most challenged. We have got some international recruits from all over the world, but only tiny numbers for learning disability. I think it was only 3 in the last couple of months. So this is where the long-term workforce plan, David and Navina, really comes into play. How we maximise every bit of that ambition to deliver those increases in supply. So for me, the long-term workforce plan is key to how we deliver some of the service improvements for this population.
Thank you. So Mary, and then Wal also, and then I'll get you, Tom, to comment, and then Amanda.
All right.
Okay, so we're going to go Mary first, I think.
Thank you very much, and thank you for the presentation, which I think does show that we're really getting a grip on the challenges that were for so long hidden, actually. So I'm delighted that they've been raised to such a sensible level for us all to focus on. But I wanted to look at item 6 about reducing reliance on mental health inpatient care in particular, because for me there are 2 things. People with learning disability and autistic people, you have described as suffering from a proportion from cancer and respiratory disease, and the same will be true. Some of those groups will have mental health problems, and somehow we've got to ensure that they get equal and swift treatment, rather than when they have a mental health problem, be admitted and then stay for years and years. And I really wanted to ask about how we're going to get the people that have been in mental health facilities out more quickly, looking at the fact, and I've highlighted this, Tom, that 2023-24 sees the continuation of the National Housing Capital Programme with an annual allocation of £13 million. Now, the average facility, if you're going to put somebody in individually with specialist support, and not all of those people will need that, will cost £500,000. So by my visioning, we've probably got 26 new homes for people a year. And yet, how many have we still got in hospitals that we'd like to get out? That's a really core question for me.
So what I'm going to do, I'm going to change my original tactic. And I'd like you to, if you want to pick up and respond actually to David and to Ruth and to Mary, and then I'll bring Wal and Amanda.
So just because mine...
Well, I'm now changing my tactic again, obviously. So, yeah.
Losing control, Richard.
Obviously.
Sorry, no, it's just to follow up on that, because actually I was interested in local authority partnerships and how work you're doing there, because of course we are but one part of the equation. There's an equally important equation which we know is, the local authorities are under incredible pressure in terms of how they support, particularly education, for example, and supporting people with learning disabilities, housing, etc. And that sort of coming together to make sure we have a balanced approach is really crucial. So, sorry, it's just a extension.
Tom.
So firstly, the gist of the paper, if I can, was about health outcomes. So you're not seeing a lot in their beds. So we just put some bed numbers in there and just begin to talk about people in hospital. But just bear with me. We do know the numbers. A year and 2 years ago, we went through, when we reviewed every individual in hospital during that period. And our estimates at the time were that about 41%, about 41% probably shouldn't be there or should be receiving care in another setting. So we've got a good sense. We've broken this number down and by ICS, and we're working really closely with the ICSs. So part of my thinking is, and you've just heard me saying, we make the problems too big so that nobody can get them. We have an understanding now, a close understanding of everybody who's in hospital and can talk in detail about them. You are right. You are right around the challenges around capital, because we know that housing is about, I think it's about 12%, 13% of those who can't, for a reason for not going out. But I wouldn't want to underplay the 13 or the 15 million. I think over the space of 2 years that placed 80 people. Okay, because we think big bang all the time. A lot of people need modifications, so we use that money really well. And any time we sell property, recycle. So it's really good, but not enough. And one of the things we're pushing on social care, and we've got a good relationship with social care and housing and the minister about, okay, what can we do more about housing? What are councils doing locally around housing that are thinking ahead? Because we have discharged 80% of people who were in hospital in 2015 are no longer there. So that's the really important figure. So things have moved. I'm not trying to sell a really positive thing here. There's still around 2,000 people in hospital, 200 kids, 1,800 adults. So just wanted to want to, but what we are seeing is a different group of people coming in for hospital and not for as long. Yeah. And we're very clear, hospital is not bad for the people who need it for a particular period of time. And that's really important that we understand that. Our target is still 30 per million, and which is really what we're trying to drive. But we've really been trying to use the data, understand what it's telling us. So we're seeing a lot more autistic people coming into hospital who need mental health support, going into slightly different hospitals, going into mental health hospitals to stay, but not going in for as long. So we have to think differently about what's the solution. So I'm more than happy to even spend some time with you offline. But I didn't come, with all that data. I don't want to paint a rosy picture, because there's many families that'll say, my son and my daughter or my sister is in hospital far too long, and we would agree with that. Equally, I can point to some fantastic work where people have been in hospital for 20, 25, 26, 27 years, and now in their new homes. We will continue to do that. There's no doubt about it. We will drive that. We will need more capital to do that, of course.
Thank you. So, Amanda, do you want to...
Oh, yeah, so thank you. So actually, what I wanted to do, if it's okay, is just to go back to the visit Tom and I did at the end of last week to the Black Country, because I think sometimes with these sorts of conversations, of course, it's absolutely right that we do focus on where things are not working as well as they can, and the leader reviews really do highlight exactly the sort of size and scale of the problem that we need to collectively lean into, and we are. And I just want, actually, if I may, just to pay tribute to Tom and his team, who are leading with such incredible passion as well as an impact, but also my colleagues who've lent into, so Navina, your work with Paula to develop the Oliver McGowan training, for example, I think has been hugely important. Ruth, your team's work as well. But what we saw in the Black Country which was really extraordinary, was what the potential is when you get it right. And actually talking to, I mean, Tom and I came back on the train together, talking to, it was Matty and the relationship he had with Duncan, his key worker. It was Nathan and the relationship he had with Dave, his carer. It was Ellie and the relationship she had with Shay, who was her carer. And the way that those young people were able to talk about their experiences and where they are now and their hopes and aspirations for the future. And that, for me, was, in a nutshell, what we've just talked about with Paula McGowan's work and the Oliver McGowan training. Ask, listen, do. That's what they have done. They have worked with those young people to understand what mattered to them and to develop and design and deliver services in a absolute example of partnership, the way we've just been talking about it. This is partnership with the voluntary sector, it's partnership with the private sector, it's partnership between commissioners and providers, it's between local authorities and the NHS. And they have made a difference, which incalculable difference to the lives of those young people. And the thing that I think I want to just encourage us to continue to do is to have that balance between all the things we know we need to do and we need to get right, but actually working with and promoting and highlighting the examples of when it goes right, because that's what we want to see everywhere. And the bit for me, Tom, is what I particularly want to talk about in this bit. Mary, you just talked about it, is the interfaces. So I think that we picked up quite a lot on Friday, didn't we? It's great if you can do it within a service which is designed for people who have specific needs, but what happens when their lives touch other parts of the system, which they do every single day? So some of the encouragement that I think you've given at the moment to colleagues in acute trusts, to colleagues in primary care, to colleagues in community trusts, which isn't, training is such a huge part of it, but it's more than that. It's the practical actions that you've just talked about with, whether it's Calder Day and Huddersfield or Sarah Jane, you were just sharing some of the practical, reasonable adjustments that you were making when you were Chief Executive just a short while ago. And the more that we can, I think across boundaries with this, the bigger impact we will make collectively.
With your permission, Chair, one reflection I've got is as a key worker, key workers of strategy, it's been really good. They help people navigate their lives. One of them was a civil engineer.
Very good. John, thank you for bringing that topic to the board, and we will be bringing you back, actually. So I think to David's point, it would be really important, I think, to keep this as a regular item. So thank you. Can we go on to item number 6, which is the 3-year delivery plan for maternity and neonatal services? And Ruth, I think you're leading, but you've got Duncan and Kate and Ngozi with you. Would you introduce them, and then the floor is yours.
Thank you very much. So just want to go back to what Richard and Amanda started with, which is acknowledging the awful events that have taken place at Countess of Chester. You can't imagine the pain and the suffering that those parents and families will go through and have been going through. Steve and I went up to Countess of Chester last week to visit the staff, and it was a truly humbling experience to be there. So starting now, then I shall talk about neonatal first. We are investing and continue to invest in neonatal capacity, both in terms of cots in the right places, but also the workforce. And I'm delighted also that we've now got our very first national neonatal nurse lead, Louise, and we're in the midst of recruiting our first ever national clinical director for neonatal critical care. Ngozi is going to speak in a moment about some of the work on data. You'll know that, of course, Bill Kirkup's review that was published October the 15th last year, so just coming up to a year, one of its key recommendations was around signalling, the future of signalling and the data. So that's really important. So now on to maternity. You'll know that since, I'm sure you'll know that, but since Sir David's retirement, I'm now the SRO for the Independent Review of Maternity Services in Nottingham. The terms of reference, and I know the board through the Quality Committee have approved our recommendation to them that we move from opt-in to opt-out. So that means that as long as the criteria outlined in the terms of reference, then cases will be seen unless, of course, families opt out. John Orkenden, the review chair, has written now to all of those families, so it is now feel as if it is really started underway. I'm pleased today to announce that we've got a new chair of our Maternity and Neonatal Board, Sam Allen, who's the Chief Executive of the North East and North Cumbria ICB. She will take over from what Sarah Jane left some months ago now, and I've been doing it in the interim period. So I'm delighted that Sam is doing it, a forceful leader, a very kind and compassionate leader, just like Sarah Jane, but also important, I think, to really stress the roles and the responsibilities and influence that ICBs have in this agenda. So that to me is really important. I'd like to say, although he's not here on record, our thanks to Matthew Jolly, who's stepping away now as the National Clinical Director. He's done it for 8 years. I think he's done his stint. So my sincere thank you to Matthew, and a welcome too to Kate Brintworth, our new Chief Midwifery Officer. Both Sam and Kate's appointment, we've involved service users. They've had the casting vote, and that has been really important about listening to families and putting them at the heart of what we're doing. So just in terms of context, in England, a baby is born every 55 seconds. There is a caesarean delivery of a baby every 2 minutes and 35 seconds. This demonstrates the scale of which maternity and neonatal services are across the whole of England, and equally the importance of delivering against this 3-year maternity and neonatal plan. I'm now going to hand over to Kate, then Ngozi, and then Duncan, and then open the floor. Thank you, Chair.
Thank you, Ruth. Good afternoon, everyone. I'm really struck by the theme that has come out from everything we've discussed about listening to women and families, the people we care for, and it has to be our priority if we're going to improve safety. And that isn't just in a clinical setting, at the bedside, or wherever we are caring for people, but that's also in how we manage, design and oversee our services. They absolutely need to be integral to everything we do. And certainly in our own team, we are really, really privileged to have a number of service users who challenge us, support us, and help us with every decision that we make. And that's exactly how it should be if we're going to set the right tone and right direction and have services that actually meet the needs and are safe for those we care for. We're replicating that at our regional level as well. We're supporting our regional colleagues with how they're working with service users and producing guidance for ICS and trusts to set that expectation that really you have to listen to those that you care for. You have to work with them, and that needs to be both for maternity and neonatal. The funding, infrastructure and resources have to be in place for both. And part of that really is about culture change. I think we would all agree that culture is at the heart of what makes a safe service. And again, it's been referenced frequently this afternoon. And it's why we've instigated a programme of leadership and support for every single maternity service in the country. And so far, 98 have started that programme. It brings together maternity, neonatal, general leadership and our obstetric colleagues to really think about how do you set a safe culture in your service? How do you make it feel a safe and welcoming place to come to work? How are you making sure you're listening to those that you care for? All services will have completed that by September 24, and all will have started it by Christmas this year, and the feedback we're having is absolutely phenomenal. But we also need to start with our students, because we need to get it right from the beginning. And so we are just about to launch our Safe Learning and Environmental Charter, which really sets the standards out of what it means to be welcomed into the service from the very beginning of your career, made to feel like you're important as a student, that what you do and say right from the start of your career is set out in the right way. And we're also investing in professional midwifery advocate support to look after the health and well-being of staff. Jim talked about the stress that our staff are under, and I think everyone would acknowledge that. So putting in that health and well-being guidance is really, really important. But we need to listen to all our staff and all voices, and we are aware that we, in our richly diverse people that we care for and our staff group, we know that there are inequities in the outcomes, and that's something that we have to tackle. We know that perinatal mortality outcomes are not the same for all ethnic groups, and that is not acceptable. We completely know that we have a lot of work to do. Similarly, our staff talk about their poor experiences, but we also know that when we invest in support, we can make a difference. So initiatives like Capital Midwife in London have supported staff. 40% of staff who undertook that programme have moved into promotion from ethnic minority backgrounds. That is making a tangible difference. And similarly, we are starting to see a shift in asking our ICSs. They willingly stepped into the space to look at the equality and equity plans that they needed to put in place to meet the needs of their population. And we are starting to see the green shoots emerging. We are all very familiar with the harrowing 5 times more statistic. The latest data from Embrace tells us that this is now just below 4. That's not a reason to be complacent, but it shows that change is possible and we can head in the right direction. And now I'd like to hand over to Ngozi to talk more about data.
Thank you. Thank you, Kate. As Ruth said, we're now approaching the first year anniversary of the publication of the review of East Kent. One of the really strong recommendations was the need to develop the ability to spot signals of concern amongst all the data that we have in neonatal services. This data is already available, but what we need to be able to do is identify trends and outliers, because we have quite a lot of data. This has led to the establishment of an outcomes group, which is chaired by my colleague Eddie Lee Murdoch. This group has now developed a set of outcome measures which we hope will be helpful in identifying these trends of concern. It includes a set of metrics which providers, regional teams, and a national overview will be able to use to be able to undertake comparisons. And I feel that this is a real step in the right direction. And I'm really pleased about this development. However, today we've heard about data from almost everybody that has spoken. Tom talked about data, the Chief Executive in her opening speech talked about data as well. And we know that there is perhaps more to be done. Vin, it's been your portfolio to look at data as well, and I was really pleased to hear about the work that you'll be undertaking. But we know that there needs to be more focus on data within neonatal and maternity services to try and link up the data that we have between maternity and neonate to try and make more to try and understand it a bit better. We also need to improve the data linkages between neonatal services and the rest of EPR services within hospitals. Currently, we have fragmented EPR services in some instances, and this doesn't help us to understand the data that we already have. So we really need to find a way of getting good data intelligence and good access to information about our services. Thank you so much. And I'll now hand over to Duncan.
Thanks, Ngozi. So I think just also you'll see in the paper that we've provided an update on the CQC inspections. I think it's really important that we listen to what we're hearing out of those inspections, and you will know from when we pulled together the 3-year delivery plan and presented that back to the board 6 months ago. We used the CQC inspections as part of putting that plan together. But we continue to look at the learning out of that, and you'll see in here there's also a focus now on triage, and all of our regional teams are providing support to trusts and systems around triage. We're waiting some further best practice guidance which has been produced by the RCOG, who we clearly work very closely with, and there's been some good examples. For example, in the southeast of England recently have held a webinar with the CQC and the people that oversees the triage programme that we have, to bring together and share that best practice and those insights from the CQC. I think one of the other things that's clearly come out of CQC inspections is the workforce, and we've talked many times to the board about the importance of the workforce within maternity and neonatal services, and I think it's really, we clearly still have variation between organisations, both in establishments and the numbers of midwives, obstetricians, neonatal nurses, etc. in post, but I think it's really important. You'll see in the paper there are some good signs, cautious good signs in some of the workforce data that we are seeing. And just to provide a few examples of that, really, we've got 600 more midwives in post than we did this time last year. We have also got increased numbers of midwives in training, and we started to see last year the benefit of that coming through. All being well, we expect about 1,400 midwives to enter the workforce, newly qualified, around about now, and that's 400 more than we had entering the workforce this time last year. So provided that happens and all goes well, and obviously the work that Kate talked about in supporting students is really important in this. If that goes well, we will hit a record number of midwives in our services by around November this year. Again, not complacent on this. We've also got programs of work continuing to run around international recruitment of midwives. We've had over 760 of those now start with us in our services, and another 200 or so to start by the end of December, and great work still going on. I can see actually we've recruited 50 more alone in August. And obviously, neonatal units have taken advantage of the nursing programme that we've run to recruit international nurses. We've had 60 more midwives start through our Return to Midwifery programme, and great to see actually record numbers of maternity support workers in our services, and that's important when we think about the long-term workforce plan and supporting people into future apprenticeship roles as well. And we've also seen, and picking up the point Julian said about temporary staff earlier, we have seen an increase actually in our temporary staff workforce within our maternity services, which you can see therefore the fact that we've increased the establishments, people are able to increase the workforce overall in those areas. But we are continuing to support our services with programmes of work. We've offered out the direct support offer to 100% of our trusts. We've had 70 of those organisations go through that now, and our next phase to go through over the next couple of months. And that's really important because that's bringing trusts together to share best practice around recruitment, retention, and other areas. So some really good signs here coming through on workforce, and we've obviously seen some increases as well in the numbers of obstetricians. And the last thing I'd just say on that is that we are also seeing local systems continuing to invest in their workforce. We know we've had a gap around establishment, and we've supported nationally, for example, 1,200 additional midwives, but we've also seen local systems invest about 900 additional midwives as well. So that is a clear goal from the delivery plan that we launched back in March, and we'll continue to monitor that going forward. Ruth.
So I'm going to, because we'll have no time for comments or questions if you present to us for the whole time. So can I go, which is a very good presentation, by the way. So Wal, you wanted to ask, and Mark, and Navina and Munir. So Wal.
So very quickly, so great progress on the 3-year plan. Great that we're focused on culture and workforce and standards and structures. The bit which I'm sort of disturbed about is the data, because that's the kind of both the guide and the evidence that it's all working. And there's commentary here about it's sort of backward looking, and it's focusing on when there's a really awful outcome, quite frankly. Yeah. And Ruth, in the past, Duncan, we've spoken about how we develop early warning systems, how we use data science to look at both qualitative and quantitative measures, and look at that to then develop a better understanding of not what CQC tells us is not doing well, but the people who are heading that way. So can you just say a bit more about that? Where have we got to with this? Because I didn't really get that. Anyway.
So we're going to gather gives you a chance to do them smoothly. Mark?
I was going to emphasise that point, actually. The data analysis needs to be done in real time. Yeah. It's no use at all unless it's done in real time. But I was also going to point out that the FDP is going to be really important for this. And actually, for the last presentation, we heard about autism and learning disability. These are all complex situations where you need the data in real time. But frankly, we can't wait for the FDP to do the real outcomes analysis, the real-time outcomes analysis in the maternity system. We just can't.
Thank you, Mark. Navina?
Yeah, sorry, mine is also about data, and it's about early warning signs and workforce. And it's great that we know about establishment increasing their thing, but I think we have a real opportunity because we already have data on staff experience, staff engagement, and we know, how people feel, inclusion, the RES data. We have all of that. We know that impacts on productivity and therefore outcomes. So early warning signs are in that space. And also now that HEE is part of NHS England, you have access to all the rich feedback that we get from students, trainees and learners. They are often very good judge of early warning signs.
Munir?
Thanks. So we have discussed this as a quality committee a couple of times. And my question was about data. I'll make one point about data and then ask something else. So the data piece is really complicated. You need the sort of data linkages that were mentioned. You need the timely data. You then need the sort of ability to be able to analyze it in real time. And the outlier analysis is not easy. But there are world-renowned experts in this country who have done this all their lives and so on, and we should be using that expertise to be able to do that kind of outlier analysis and so on. So I think that's just a comment. The question then is about listening, and it's very nicely laid out about listening to patients and families. What about listening to staff as well? And can you just unpack that as well?
And then I'm going to give you one other topic. And it's really good that this comes up at this area comes up at the Quality Committee with frequency, Munir, and thank you for that. Mine's going to be a slightly more crockery-breaking comment. So I read this very good paper, and I read a whole host of initiatives and frameworks and guidance and structures. And if I'm in a maternity unit, neonatal unit, and I'm looking up at all of these potential programs and frameworks, initiatives, etc., not knowing what I'm talking about, are there too many? Is there actually a simplification that can be done? And instead of adding another initiative to get this area better, and I realise it's a dangerous question, but to get this better, if you looked up at all of the things that we from the centre are asking and offering and challenged with, I'm sure they're all good in their own right, but is there a synthesis that can be done that might actually enable them to be delivered with more coherence? And it's probably a stupid question, but would you like to have a go at all of the comments from the board?
Absolutely. So I'll pass some of them down the chain with the colleagues as well. Yeah, I'll be really brief. So the I'll do the last bit first. That was the purpose of the 3-year delivery plan. How we took East Kent, Don Walkington's recommendations, plus our previous programme, combined it into something that was much more succinct and into our key areas. Listening to staff, I'll pass on. The data is vital, and that's exactly what the Reading the Signals report that Bill Kirkup's East Kent report actually said. We need to do it, and that's the work that we're doing. So we've got Dr. Murdoch, we've got Bill Kirkup, we've got a whole range of people, and Dozy can talk even more about it. But we've got that work that's been looking at, with all of the analysts, yes, we'll link up, Vin, absolutely. We've got those measurements now, but it's important to test. We've done some initial testing on one of our units, and actually it would have picked it up sooner. So we've got some very early testing, but it's important that we just use this next couple of months just to test that out before we roll anything out.
Yeah, I think just to add to that, Ruth, so by the end of Q3, we'll have done that testing, and by the end of Q4, we will have those of this year. We will have those tests complete and be able to come out with something. And I think, it's just to say, Ruth, it is really important that we do get that right so that we don't send people looking at the wrong thing as an early warning indicator. I think the other thing, there's a lot of other data wrap around this. So we've just adjusted the SITREP that we had for COVID for maternity services so that we've got better operational data coming through on a regular basis, looking at the pressures in maternity services. There's been some good work that's been done with the Number 10 AI team as well, looking at the HSIB reports, but it is really complex because this is multiple organisations trying to, with lots of different sources of information. So we're also at the same time going to be rolling out next year a single notification portal so that it makes it easier for trusts to report incidents, etc., so that they're not having to report in 3 different ways to 3 different organisations, and so that we're much more joined up at the centre, just taking that point about people looking up and actually how are we more coherent on this.
And lastly, I'll just add that in the data group, I didn't mention that it also includes workforce metrics, so we can triangulate that as well. It includes parental information as well, so we can also include that as well, because I think that's really important to demonstrate that we're listening. So when we finally have the complete group, it will take all these metrics into account to give us a picture of how our services is doing.
Very good, thank you. I think you've answered probably or reflected on all the comments.
Sorry to be pedantic, but I would really like to understand more about this, and I think it'd be nice if it came back to the board, because all the questions about data, and I didn't hear Duncan. I didn't hear near misses, which is one of the things we talked about, which is really important. You learn as much from near misses as you do from actual.
We might set it up as we might set up as a board called Deep Dive, rather than a board meeting.
I know the team would really value this expertise and that eyes, that'd be helpful. The listening to staff, we didn't answer. Did you want to quickly say?
Yeah, part of that leadership programme that I talked about is helping units understand their own staff, but we've been having multiple listening events, and equally at the regions, they're very much listening to students and trainees and what they're saying. When you look at how a service is doing, it's a very complicated picture where you need to weave together the threads of multiple elements. It's not just about outcome data, it's what the staff say, it's what the feedback you get from parents, it's how organisations respond to initiatives like CNST or Saving Babies' Lives. So it is complex, Richard, in answer to your question, but we are trying our best to simplify.
Very good. Okay, thank you. Look, I'm going to move us on and just, this is being live streamed, but also we've got some guests, members of the public guests, just to forewarn you, I'm afraid I'm going to lose the discipline. We're probably going to go 5 minutes over the end time, just to forewarn you, but with apologies. So let's go to the last substantive item, which is urgent and emergency care services. Sarah Jane.
Thank you, Chair, and I'll keep it quite concise. Hopefully the paper's clear, and I know we'll want a bit of time for discussion. So just a few headlines to refresh people. We published the UEC Recovery Plan in January of this year. The main focus of the UEC Recovery Plan was improving our ambulance response times and our emergency department performance. But we recognise to do that, what we really need to achieve is flow throughout our urgent and emergency care pathways. And the plan set out 5 key ways that we were going about doing that. One was increasing capacity. One was about increasing size of workforce and the way that people work. The third was improving discharge. The fourth was care outside hospital, particularly services that helped to not admit patients in the first place. And then the fifth was making it easier to navigate our healthcare systems. We've made significant inroads into delivering against those commitments. So in August of this year compared to August of last year, we were 11 minutes faster with our Category 2 ambulance response times, which we know is crucial. We know it's a fundamental bedrock of the NHS, that if you are in need of emergency care, in need of an ambulance, one comes to you in a timely way. So those 11 minutes are crucial. We also saw a 1% improvement in our emergency department performance against a backdrop of a 2.4% increase in attendances and a 6.8% increase in admissions. And probably the most impressive of the statistics, I think, is that in August, the average number of patients in hospital that remained for 14 days or more was down by 13% on where it was in January of this year. And we know that if we can keep our length of stay under control, if we can get that to come down, that really is a marker of flow and ability to be able to admit patients through pathways. So we are in a better position than we were this time last year, and that is as a result of the fantastic work that the NHS has done to implement the UEC Recovery Plan. We're also on track in terms of the headline admissions, in particular 5,000 additional G&A beds and 10,000 virtual ward beds, and we've been doing some brilliant work with our colleagues in social care on the transfer of care hubs to make sure that every patient leaving hospital with a set of more complex needs gets a proper assessment and gets the best pathway for them. We've published our intermediate care framework, which we discussed in our board deep dive yesterday in some detail. And we've been working with all systems on the 10 high impact interventions that were set out in the winter letter to make sure that our systems have got support to do the right combination for them. So just to conclude, we have also been working then on the winter planning element. Clearly the UEC recovery plan is for 12 months of the year, but we know we need to be really tight in the way that we approach this winter. So we've been working with each of our systems on their plans, which we've now got back. And we've had a particular focus on those where there are gaps in capacity and challenges. In general, we have seen a robust response to that. Each of our systems have got plans to have the capacity in place across the pathway to meet the expected demands over winter. However, there are some risks. While that is generically true across the NHS, there are some individual systems that, for a range, often of historic reasons, are not as resilient as some others. So there do remain a small number of systems that we're concerned about and continuing to do work with. They're predominantly those in our tier 1 that we work with closely anyway. We discussed earlier, but I think it's important just to say again that industrial action, both in terms of operational impact, we will see from the, they're not finalised figures for September yet, but we will see our emergency performance in September was impacted by the periods of industrial action. And we are also seeing, as people are putting that additional capacity in place in the lead up to winter, that the interactions with the financial challenges are very much in the forefront. And then whilst we're talking about the NHS financial situation here, the resilience of the plans also depends on social care capacity as well. And whilst we have seen significant increases in social care capacity through the course of the year, and that is one of the drivers of that really impressive statistic of the 13% reduction, there are some local authorities, as we know, that have got a range of challenges, and there are some individual places where some of that additional capacity is now at risk. So I think we just need to note that as well. So pleased with where we've got to. We've got robust plans going into this winter, but there's definitely residual risk in a number of places, and then sort of more generically driven by industrial action and then some of the financial constraints that the NHS and social care are operating under.
Thank you. Questions or comments for Sarah Jane? Well, Mary first and then Well,
I was just going to say that I think it's a really comprehensive report and shows that we've done everything we can to focus on the issues that you've outlined, but acknowledging that industrial action challenges everything, particularly as we approach the winter.
Well,
I do agree with that. I'm just a question on the data and the feedback loop on, in sort of real time as to what's going on. Can you just comment a bit more about that? Because I know you've improved that a lot, and that's what this whole thing depends on. And that was, should we say, something we needed to improve on dramatically.
Yeah.
Have been needed to improve on dramatically over time.
So at every level, there's been massive improvements, I think, over the last 12 months. So the first thing is we've got more use of data management inside organisations themselves. We've got our flagship projects around electronic bed management, but really making sure that sort of site teams have got that clear line of sight. We've talked about the transfer of care hub. That's a key part of that as well. Then we've got our system control centres, so that there's an overview of all of the different parts of capacity in a system, and people are having those conversations about clinical risk and the best ways to move patients and resources across particular parts of the pathway. There's some brilliant work being done on data sharing, some great examples of what we can start to achieve through that shared view. And then we've also got really tight operational management oversight in NHS England via both our regional and national teams. So we have at least a daily check-in on real-time data. We're looking at that particular moment in time, where have we got ambulances that have been queuing too long, where have we got people who've been in emergency departments, where have we got a lack of flow and discharge. If there are particular issues, we do that at 11 o'clock every day, 7 days a week in the winter. Then we can reconvene that at a particular point in time or with a particular system. And our job as NHS England then is to get alongside those places and just help and support with our expertise to see whether there's anything that we can unblock. And increasingly we've been using our more senior clinicians as part of that as well, and actually asking some of the escalations to be the clinical to clinical escalation, because we know really, and that comes back to industrial action, when things really silt up, it is about getting those senior decision makers on the ground able to discharge patients and so on. So it is intense, and it's been particularly intense for those teams during industrial action, because they actually do that on a 3-hourly rhythm, because clearly 24 hours, is too long between that. But that's our responsibility, and that's what we set up to do through the operations centre as we go into winter.
So I'm going to ask Jim if he has any additional comments in a moment. Just that triage point, front door triage point, is often quite a good intervention, isn't it? In terms of when I've gone around various of the systems to see those who will put, say, GPs at the front door, yes, or more senior clinicians at the front door under times of great stress. I mean, that seems to have real effectiveness, and I always have to mention it, but I have been told I'm completely wrong on both on both of these. I always want to know about fast response vehicles as proportions of ambulance fleets, but we can pick it up outside the board. I still can't quite understand the logic about why we wouldn't have more fast response, because the proportions that each ambulance trust hold of fast response are very, very different, and I don't understand the logic of that. And the other one I'm always puzzled by is when we see ambulances stacked up, actually why, again, we won't move ambulances to nearby, so it's not necessarily in rural, but nearby hospitals within similar urban configurations. And I'm told it's because actually once checked in, actually the risk of moving the patient is more difficult. Mm-hmm. But actually that, rather than waiting in the back of an ambulance for 6 or 7 or 8 hours, if there's a nearby hospital where there's an easier access, but I don't answer them now, but as you know, I keep banging on at those two points. But anyway, Jim, have you got any additional comments you'd like to make to close out the conversation?
Really, I think the last few weeks has been a bit of a limbering up on this in terms of support for people during industrial action. So that I think that's been incredibly helpful in some very challenged places. And just really emphasise the value of the clinical interaction there as well, which has been hugely beneficial in the elective programme as well, and mobilising it in urgent care has been excellent to see.
Very good. Sarah Jane, thank you for all you're doing in this, and for all the teams, actually. Thank you very much. That's the last substantive item. I think we've got just 2 items to note. One is just on the Atomis, I think that's the pronunciation, the Atomis rollout, which is an e-commercial system for procurement. It's essentially centrally contracted by the Department of Health very helpfully. The platform currently holds a pipeline worth £42 billion and active contracts with a combined value of over £120 billion across 11,000 suppliers. As this comes together, the ability of the NHS and the other arm's length bodies within the health system actually to manage their supplier base and the costs and the efficiency and effectiveness of delivery will improve. So this is just for the board, I think, to note, and any questions or comments, I think, to Jackie Rock, who is leading for us in this space. And then the last item is simply for us to note the use of the NHS England seal in the period, I think, between 24th of March 23 to 19th of September. And you'll see that the seal has been applied on a number of various programmes and authorisations. So if we note those, can I pause? Is there any other business from the board? Can I thank you very much again for all the engagement since the last board. I referenced at the start in all the committee work that you do in the 2 strategy boards, the board deep dive that we've had. Thank you very much, and thank you for today. Very good.